Hi guys, today we're going to continue our discussion of the thorax, and we'll focus specifically on the thoracic cavity, so the internal or deep regions of the thorax. The video is specifically going to cover the lungs and the pleura. We'll handle the heart and the pericardium in a later video. The thoracic cavity refers to the space that's enclosed by the thoracic walls. So really the space between the diaphragm on the inferior edge and the neck on the superior edge. When we look at the thoracic cavity, it's further subdivided inside into the right and left pulmonary cavities or pleural cavities, which each house a lung and are surrounded by the double layer membrane that we call the pleura, right? The visceral pleura and parietal pleura. In between the right and left pulmonary cavities, we have a region that we refer to as the mediastinum, right? Think medial in the middle. The mediastinum contains the heart, which remember is surrounded by the pericardium. So the heart is in the pericardial cavity. And this is in the inferior portion of the mediastinum. The superior portions of the mediastinum contain the great vessels that connect to the heart. So by this I mean the aorta and its branches, the pulmonary trunk and pulmonary arteries, the pulmonary veins, the superior and inferior vena cava, all of the large vessels that are connecting to the heart. We also see the trachea, and we'll also see where the trachea splits into the main bronchi. The esophagus is present, passing through the mediastinum and then eventually through the esophagus down into the abdominal cavity. We see the thymus present, part of the lymphatic system, and then also lymph nodes and lymphatic vessels. So each of the lungs is enclosed in a double layered membrane or a double layered pleural sac. So we have two distinct pleural sacs, one around the left lung and one around the right lung. They're independent of each other. The pleural sac, again, is double layered. It has two layers, just like we see with the pericardium around the heart and the peritoneum in the abdomen. These are all double layered membranes. They each have a visceral layer and a parietal layer. The visceral layer is the inner layer or the deep layer that's directly on the surface of the lung. So the visceral pleura is it's a thin, delicate layer that follows all of the contours of the lung. It even dips down into the fissures. Remember, a fissure is like a deep crevice. And our lungs, we'll see, have fissures that divide the lung itself up into sections or lobes. So the visceral pleura is going to dip down into all of these fissures as well. The parietal pleura then is the outer layer or the more superficial layer. The parietal pleura lines the pulmonary cavity, okay, which is the space between the two layers. And on the outer side, it adheres to the internal thoracic wall, mediastinum, and diaphragm. Okay, so essentially the parietal layer is lining the body wall, right? It's lining all of the structures that surround the pleural cavity. So on its lateral and posterior borders, it's lining the thoracic wall. On its medial borders, it's lining the mediastinum, and then on the inferior border of the cavity, it's lining the diaphragm, which remember sits right underneath the pleural cavities. So we have these two layers, right? We have the visceral pleura on the inside and then the parietal pleura on the outside. The little space that's between them is referred to as the pleural cavity. And this is a potential space. It's not like an open space with air flowing through it. It should not have air in it. So the pleural cavity is this potential space between the two layers of pleura. And the pleural cavity contains a small amount of pleural fluid or serous fluid. This fluid is important for a couple reasons. One, it provides lubrication, right? We have these two membranes and the lungs are moving, right? And the thoracic cavity is moving. During inhalation and exhalation, we have an expansion and then a deflation of the pleural cavities and of the lungs. As this happens, as the movement is happening, we don't want friction to occur, right? If the lungs are rubbing up against the body wall or any of the structures in the mediastinum like this, it's going to generate friction, and friction can damage the delicate tissue. So the lubrication that this serous fluid provides is important because it decreases friction. The fluid is also important because it provides surface tension. Right? Remember, water is a polar molecule, so it forms hydrogen bonds with other water molecules. And so the fluid has mostly water, and it has a good amount of surface tension or adhesion. And what this does is this surface tension helps to hold these two layers together, right? So it helps to hold the visceral layer and the lungs out to the parietal layer, which is connected with the thoracic wall. So think of the surface tension as this attraction between the lungs and the thoracic wall. It keeps them in contact with each other so that the lungs don't just deflate with all of the changing pressure and the elasticity. The lungs are really elastic, so they want to just snap in. The surface tension between the two layers helps to keep the lungs inflated and in contact with the thoracic wall. The endothoracic fascia is a thin layer of fibrous areolar connective tissue that's between the inner thoracic wall and the parietal pleura. So between the parietal pleura and the inner thoracic wall, there's this really thin layer of areolar and connective tissue. This endothoracic fascia is important for you guys because it provides a cleavage plane that surgeons can use when gaining access to the structures inside the thoracic cavity. What I mean by that is you can actually separate the parietal pleura from the thoracic wall, right along this plane, right along this endothoracic fascia. You can go in and separate the parietal pleura from the thoracic wall, and then that provides area where you can go through the membranes and access the structures that are in the thoracic cavity. So there are multiple parts of the pleura. We can separate the pleura into different regions. First off, there's something called a pleural sleeve. And the pleural sleeve is the area that's enclosing the root of the lung. If you look on the kind of posterior medial regions of the lung, so if this is the lung, right, but on like the back, right around this area. So on the back in this area, we have the root, and this is the area where things are entering and leaving the lung. So the pulmonary artery, the pulmonary veins, the main bronchi, the bronchial artery, the nerves are entering and leaving the lung via this root. This area of the lung is enclosed with the pleural sleeve. This also happens to be the area where the two layers of the pleura are continuous with each other. Remember, we said that the inner layer is the visceral layer, and then that continues around and connects to the outer layer or the parietal layer. The area where they actually connect with each other, where they're continuous, occurs here at the root. Okay, so this, I just drew it here so you could actually see it, but that's occurring in the back of the lung at the root. Okay, they're continuous there at the root of the lung where the pleural sleeve is created. The membranes, the pleura at this area also form something called the pulmonary ligament. The pulmonary ligament extends out from the root of the lung in towards the mediastinum, right? And remember that the area here between the lungs is the mediastinum. Okay, so the pulmonary ligament is extending from the root in towards the mediastinum, right? And that's structural support for the lung. Now, the parietal pleura can be broken up into 4 different regions, just depending on where it is, right, and what it's lining. The costal part, the largest part of the parietal pleura, is lining the internal surfaces of the thoracic wall. Right, so all of this was the thoracic wall. Remember, it includes the ribs, the costal cartilages, the intercostal muscles, what else? The anterior aspect of the thoracic vertebrae. All of the structures that are in the thoracic wall, okay, their inner surface is lined with the costal region of the parietal pleura. Remember that this parietal pleura is separated from the actual thoracic wall by the endothoracic fascia, right? And we talked about the endothoracic fascia 1 second ago. We said that that's a nice area to cleave between the wall and the thoracic cavity when doing surgery. So that's the costal part. There's also a mediastinal part of the parietal pleura, and that's just the most medial region of the parietal pleura. That's the region in here that's lining the lateral aspects of the mediastinum. The diaphragmatic portion of the parietal pleura is the inferior region of the parietal pleura, right? This is covering or lining the diaphragm on either side of the mediastinum. So the region of the parietal pleura over here that's lining the diaphragm, and the region over here that's lining the diaphragm. Remember, if we talk about the diaphragm is this dome-shaped muscle, right, that almost completely forms a barrier between the thoracic cavity and the abdominal cavity. So the diaphragmatic part of the parietal pleura lines the diaphragm right here and then over here as well. Finally, the cervical pleura. The cervical pleura actually extends up out of the thoracic cavity. Or out of the thorax itself and into the neck. So the cervical pleura extends up through the superior thoracic aperture, which remember is like this passageway right here between the thoracic cavity and the neck. So the cervical portion of the pleura extends through that superior thoracic aperture, and it goes up to up into the neck to about the level of the first rib. The middle portion of the first rib. So what this cervical pleura does is it forms this little cup-shaped dome that's right over the apex of the lung. Right, so it just pops up a little bit above this the superior thoracic aperture and just covers the apex of the lung up at the top. That's the apex. The base or diaphragmatic surface, we'll see in a second, is the inferior surface. So here we see the different parts of the pleura. Okay, just to get your bearings, remember the trachea brings air down and it splits into the main bronchi. And the main bronchi bring air into the lungs, and then they continue to split into the bronchial tree. In the center here, you see the lung itself. At the bottom, you see the diaphragm. And then on the outer surfaces here, you see the actual thoracic wall. So the ribs and costal cartilages, the intercostal muscles, the thoracic vertebrae in the back are all forming that thoracic wall. In orange, you see the inner layer of the pleura, the visceral pleura. So that's just lining the surface of the lung all the way around. On the outside, right, then the space is the pleural cavity, which has serous fluid in it. And then the outer region is the parietal pleura. And the parietal pleura is represented by all different colors because it's showing us the different regions of the parietal pleura. So the costal pleura is the region that's lateral here in light blue, and it goes around the back of the lung. And that's the portion, remember, that's lining the internal thoracic wall. Remember, the cervical pleura is the part that goes up into the cervical region, right? It actually goes up through the superior thoracic aperture, which would be like right here. It proceeds, it goes through that, and the cervical pleura actually goes up into the neck. So that's what you see here in yellow. The mediastinal pleura, which is shown in purple, lines the lateral aspects of the mediastinum. And then finally, the diaphragmatic pleura, it lines the inferior region here, where the diaphragm is. We also have what we call planes or lines of reflection, and there are 3 of them. There is the sternal line of pleural reflection, and then there's also a vertebral line of pleural reflection and a costal line of pleural reflection. And these reflection lines just refer to the areas where one region of the parietal pleura turns sharply to become another region of the parietal pleura. And the names kind of tell you specifically where they are, but let's talk about them. So the sternal line of pleural reflection. The sternum is in the front center, right? So that refers to the area where the costal pleura in the front turns sharply to become the mediastinal or mediastinal pleura. Okay, so the costal pleura is coming around the front, and then it turns sharply to line the mediastinum. That turn, that sharp turn in the front of the heart is the sternal line of pleural reflection. The vertebral line of pleural reflection is in the back. That makes sense. That's where the vertebrae are. So the vertebral line of pleural reflection refers to the area where the costal pleura in the back takes a sharp turn towards the front to become the mediastinal pleura. Okay, so again, around the back, we have the costal pleura, right? It's coming in and lining the back, and when it gets to the vertebrae, it's going to take a sharp turn forward to line the mediastinum. Okay, that sharp turn in the back is the vertebral line of pleural reflection. Finally, we have the costal line of pleural reflection. This is the only one that's not obvious by the name, but the costal line occurs where at the area where the costal pleura takes a sharp turn and becomes the diaphragmatic pleura. So that's at the bottom of the heart. Okay, so along the inferior ridge of the heart, or inferior lateral ridge, is the costal line. In the back medial region is the vertebral line, and in the front medial region is the sternal line of pleural reflection. Okay, during inspiration, the lungs expand, right, pulling air in, and during expiration, when we exhale, the lungs deflate. So there's this constant kind of movement of the lungs. During expiration, we see that the lungs don't fully occupy the pleural cavity. There are spaces, specifically at the bottom and then some on the medial aspects of the lung. But there are spaces that the lung is not fully occupying the pleural cavity. So in these spaces, the two pleural membranes are just separated by serous fluid. There's no actual lung tissue in that area. So these two spaces in the pleural cavities are the costodiaphragmatic recesses, which are large, and the costomediastinal recesses, which are smaller. Costodiaphragmatic refer to the recesses that are down here, the bottom, the inferior regions by the diaphragm, and then they also kind of creep up a little right here, hence the costo. The costomediastinal recesses are in towards the mediastinum, so towards the medial aspects. They're kind of hard to see on here though, because they tend to kind of creep behind the sternum and behind the lung. When you look at the spaces, you'll see that it is a little bit larger in the left pleural cavity. The costomediastinal recess is a little bit larger in the left pleural cavity than the right, because the left lung has this cardiac notch taken out of it. So because of the cardiac notch, the left lung looks like this. Okay, so because that cardiac notch is there, that allows for a little bit of additional space in comparison to the right lung. From the outside of the body, you should be able to pinpoint certain areas that will trace the borders of the parietal pleura. So they'll give you an outline for where the pleural cavities are. Okay, so here we'll see the superior borders, right, that mark the very top or the the apex of the lungs. We have anterior borders that show you the most anterior and medial regions of the lungs. We have the lateral borders that show us, where the pleural cavity is as it stretches around towards the back, and then posterior borders. So again, kind of marking each of these points, then drawing a line between all of the points shows you where the pleural cavities are. The superiormost border is in the root of the neck, okay, so the inferior regions of the neck, just superior and posterior to the clavicle. Okay, so your clavicle, right, you can feel your collarbone here. And if you go just superior and inferior to the clavicle, you can pinpoint where the superiormost border of the pleural cavity is. Going to the anteriormost borders, you're going to find the second costal cartilage, which remember is at the sternal angle. When we did the sternum, you can find your jugular notch, your manubrium, and then palpating down, you feel an anterior ridge, which is the sternal angle. And we said that the sternal angle was at the second costal cartilage. Okay, so you can palpate the second costal cartilage and count down, right, to 3 and 4. And that's showing you the anteriormost border of the pleural cavity. Now, this second to fourth costal cartilage is really most accurate on the left side or the left lung. And the reason for that is, remember, the left lung has this cardiac notch, this little area that's taken out, which you see right here. The right lung does not have that area. So the right lung has a longer anterior border. right? The anterior border actually extends down lower in the right lung. And the right lung, it extends down to the 6th costal cartilage. Okay, so you see here, the 2nd down to the 6th costal cartilage. I went a little long there. So we can find the top of the pleural cavity. We can trace down the anterior or front of the pleural cavity. Now we need to start making our way out laterally. And the way that we do that is by just kind of picking a couple points. We go from the mid-clavicular line to the mid-axillary line to the scapular line, and we can just kind of trace the border of the pleural cavity that way. The mid-clavicular line, remember, is just in the middle of the clavicle. And if you go down the middle of the clavicle, you'll find that the pleural cavity is at about the level of the 8th costal cartilage. Okay, so this was my mid-clavicular line. I go down, and my pleural cavity would be at my 8th costal cartilage. The mid-axillary line, remember, you raise the arm, right? And in the middle of the axilla, you draw a line down. So my mid-axillary line on the lateral aspect, we need to go all the way down to the 10th rib. Okay, so extending down to the 10th rib, it's going to show us, sorry, this isn't writing exactly where I want it to, is going to show us where this lateralmost aspect, where the lateralmost aspect of the pleural cavity is. Then finally in the back, at the scapular line, we go all the way down to the 12th rib. And that's showing us the inferior and inferiormost region of the pleural cavity. Okay, so drawing a line across the bottom, right? We go from the 12th rib at the scapular line to the T12 vertebral spinous process. And again, there's our posterior border. Slightly messy, but hopefully you can kind of follow along and do it on yourself. Palpate on yourself and draw it, right? See if you can draw each of the areas and kind of trace the outline of the pleural cavity. You might look funny next time you go to the beach with the lines all over you, but it'll be helpful. So looking at the lungs themselves, the lung tissue is relatively soft and spongy in a healthy lung. In smoker's lung or diseased and fibrotic lungs, the lungs can lose that nice soft elastic tissue. And then also when we do dissections in cadavers, the lungs are harder in the cadaver. But in a living person with healthy lungs, they are soft and spongy. This elasticity is helpful for exhalation, right? We use muscles to open the rib cage and depress the diaphragm and expand the thoracic cavity. But when we relax those muscles, we have elasticity of the thoracic cage and the lungs, and all that elasticity brings it back to where it came from so that we can push air out and exhale. If the lungs were taken out of the thoracic cavity or the thoracic wall, they would actually recoil to about 1/3 of their size. And we see this recoiling if there's a puncture in the thoracic cavity and in the pleural cavity. The lungs will actually collapse. The reason for this is there's a couple of reasons for this. One is a negative pressure. There's negative pressure that exists between the pleural membranes. So in the pleural cavity, there is a negative pressure, meaning the pressure is always less than atmospheric pressure. And that helps to kind of like suction out the membranes in the lungs themselves to keep them inflated. Also, remember we just said that there is a surface tension that helps to hold the two pleural membranes together. So the combination of the surface tension of the serous fluid with the negative pressure that's in that pleural cavity helps to keep the lungs inflated as long as the thoracic cavity is intact. When we look at the lungs, we can divide each lung up into lobes, and we see that the overall shape of the lung creates an apex and a base. The apex of any organ is this, the free-floating point of the organ. So we'll see that the heart also has an apex and a base. On the lungs, the apex happens to be at the top. So here we have this top, it kind of tapers to a point. Free area that's not anchored or connected in any way. So this is the apex of the heart. The base of the heart refers to this inferior portion down here. And the base is where the heart is actually, the base refers to where the lungs are actually secured, and they're secured there to the diaphragm. The surface of the lung that sits on the diaphragm we refer to as the diaphragmatic surface. Again, that's the inferior region of the heart. And this is a convex curve. The diaphragm gives us this convex curvature here as it flexes up into the thoracic cavity. So the right lungs and left lung, or the right and left lungs are different in size and shape and kind of general structure as well. The right lung is larger and heavier and has more mass than the left lung does. And one of the reasons for that is that when you look at the left lung, you have this cardiac notch taken out, right? And this actually it's larger in the posterior portion of the heart. So as you kind of cut into the notch and go towards the back, there's a decent amount of mass that is missing from the left lung. And think about that. What sits right between the lungs? Remember that the heart sits right between the lungs. And what side of the heart is bigger? The left, right? So there's much more mass to the left of the midline than there is to the right. So like if you draw a line down the median plane, 2/3 of the mass of the heart is on the left side versus 1/3 on the right. So the heart takes up space away from the lungs. So the left lung is smaller and lighter. The right lung is heavier and more massive. It has more actual lung tissue. Also, when we look at the right lung, we see that the right lung is shorter than the left, but it's wider. So we just said why it's wider, right? The left lung has the cardiac notch taken out. The right lung does not. There's less cardiac mass on the right side, so the right lung can extend in further medially, so it is wider, and that's where a lot of that mass comes from. It's shorter. The reason that the right lung is shorter has to do with the placement and size of the liver. Okay, so remember the liver is right here, right below the diaphragm. And if you remember back to AMP1, think about the lobes of the liver, right? The liver has 4 lobes, the right, left, caudate, and quadrate. And looking at the right and left lobes, they're very different in size, right? The biggest by far lobe of the liver is this right lobe. Okay, so the right lobe of the liver comes up underneath the ribs pretty far, and it's really large, so that means that the right lung has to be a little bit shorter and further up to accommodate the right lobe of the liver. Now, when we look at the lungs, again, the lungs are divided into large sections that we call lobes. And the right lung has 3 lobes. The left lung has only 2 lobes. The lung tissue is divided up by deep grooves that are called fissures. And the right lung has 2 fissures. The left lung has 1. So when we look at the right lung has this oblique fissure, right? It's at an oblique or kind of diagonal angle, and it also has a horizontal fissure. So the two fissures divide the lung up into its three lobes. It's superior lobe, middle lobe, and inferior lobe. The left lung only has the oblique fissure. Okay, so the oblique fissure is cutting up diagonally. Because it only has one fissure, it only has two lobes. So the left lung only has the superior lobe and the inferior lobe. Let me show you, I didn't mention, over here when we talk about the cardiac notch, right, it kind of cuts into the tissue of the left lung and it creates this little like hook, right? It creates this little hook of lung tissue that comes out like this. That's called the lingula. Someone thought it looked like a tongue, right? And lingual means tongue, so lingula is what the name of that is. So we said that each lung has a root, and the root is where it has all of the structures that are kind of coming in and entering or leaving the lung. Think of it kind of like the roots of a tree. The roots of the tree branch out from the tree, and that's where the tree gets all of its nutrients, right? It pulls up nutrients from the soil, it pulls up water from the soil, everything is coming in through the root. When we look at the lungs, the lung at the root has a bunch of branches coming out, and those branches bring things that it needs. The branches bring air, right, through the bronchi. The branches bring blood through the vessels. Okay, so the branches are bringing bringing things in and out of the lungs at the root. So the root of the lung, remember we said, is enclosed by the pleural sleeve. And remember at this pleural sleeve, that's where the two layers of the pleura connect. Right, where they're where the parietal and visceral layers are continuous with each other here at the pleural sleeve around the root of the lung. Again, this is the area where the structures enter and leave the lung, and the kind of slit or opening in the lung where they're specifically entering and leaving is called the hilum. Okay, like the indented area. The things that are entering and leaving the lung include the vascular structures, the pulmonary artery, and then also two pulmonary veins. Remember, there's a superior and an inferior pulmonary vein on each side. The main bronchus, bronchus is just singular, bronchi is plural. Remember that coming off of the trachea, we have two main bronchi. And those bronchi are going to enter into the lung through the hilum, right, as part of the root. And then also we have bronchial vessels that feed the bronchi themselves. We've got lymphatic vessels, we have nerves that all enter in via this root of the lung. When we look at the roots, there's a typical kind of organization of all of these structures. The pulmonary arteries are typically the most superior. So like if we were to like take a section of the root and look at the way that it was organized, we would see that the pulmonary arteries are normally like on the top. The pulmonary veins are normally like anterior and posterior. The main bronchus is typically posterior. And that's kind of the way that it's organized. We'll see on the next slide, though, the left and right versions. So here you can see that. Right, we're looking at the back of the lungs, right, or the dorsal aspect of the lungs. So remember, the root and the hilum is on the dorsal aspect. When we look at the lungs from the front, or the anterior aspect, we're not seeing any of this, right? We're just seeing lung tissue, and we're seeing the fissures and the different lobes. And you can also see the cardiac notch in the lingula. Now looking at the posterior aspect of the lungs, now we can see the root. So specifically what we're looking at, the hilum is this slit, right? This slit-like indentation where things can enter or leave. The root refers to the actual structure itself. Okay, all of these tubes essentially enclosed in the sleeve is showing us the root, if that makes sense. So again, you can see the parietal and visceral pleura here forming the sleeve, right? The surroundings around all of the structures that are entering and leaving at the root. You see the bronchus, okay, that's in the back. You see the pulmonary artery at the top. You see the pulmonary veins at the bottom. Okay, bottom back. So this is the front, okay, where the cardiac notch is. This is the back. Okay, so again, you see the bronchus in the back. You see the pulmonary artery at the top. You see the superior and inferior pulmonary veins in the bottom, and bottom kind of towards the back. Here's the pulmonary ligament. Remember we said that the pleura come and they form the sleeve, and then from the sleeve there's an extension of the fibrous tissue, and that connects to the mediastinum in the middle. Okay, again, to provide support and structure. What else? Oh, the only other thing to notice here, and this is more physiology, but the only other thing to notice here is notice the coloring on these pulmonary arteries and pulmonary veins. This is weird. Normally, arteries are colored red because they have oxygenated blood, and veins have deoxygenated blood. Remember, pulmonary circulation is the only circumstance where that is flip-flopped, because we're sending the blood to the lungs to pick up air. Those arteries are actually carrying deoxygenated blood. Okay, they're arteries because they're going away from the heart, but they're actually carrying deoxygenated blood. So note, we color them typically blue. The pulmonary veins, the superior and inferior pulmonary veins, are veins because they're going back towards the heart, but they just got oxygen from the lungs, so they're going to be carrying oxygenated blood. It's only kind of odd thing to note. Okay, so this is really just describing the whole bronchial tree. The bronchial tree includes the tubes that carry air down into the chest, and then to each lung, and then within each lung, they carry air to each of the bronchopulmonary segments, and then eventually to each alveolar sac, okay, so to the lung tissue. Here you see, this is the trachea, right? So the one single tube that carries air down into the chest, right? That's like the trunk of the tree, is the trachea. At the level of the sternal angle, okay, so the sternal, at the level of the sternal angle, so the anterior ridge between the manubrium and the body of the sternum, is where we have what's called bifurcation of the trachea. Bi meaning two. So this single trachea V's or splits at its bifurcation and gives us two what we call main bronchi. Okay, so the left main bronchus and the right main bronchus. And these obviously are going to either side of the chest. Right, so the main bronchi are going to be delivering air to each of the lungs. Now, the right main bronchus and left main bronchus are slightly different structurally. The right main bronchus is typically wider and shorter. It doesn't have as far to go to get to the right lung, so it's shorter. And then it just passes directly into the hilum of the right lung and ends up branching to give three lobar bronchi. So we have main bronchi, and then those branch to give us lobar bronchi that go to each of the lobes. Remember, the right lung has 3 lobes in the right lung. So it makes sense that we would end up having 3 lobar bronchi to go to each of those lobes. After the lobar bronchi, we have a third level of bronchi, and these are called segmental bronchi. The segmental bronchi are going to supply air to, each segmental bronchus gives air to a single bronchopulmonary segment. So a bronchopulmonary segment is kind of like a pyramidal shaped cluster of lung tissue. And the way that the pyramid is shaped is the broad end is like around the outer regions of the lung, and the apex is pointed in towards the hilum. Okay, so like from the pleural surface in towards the hilum, there are these pyramids that radiate out and little segments of lung tissue. Each segment is called a bronchopulmonary segment, and each bronchopulmonary segment is fed air by a segmental bronchus. So we go main bronchi, lobar bronchi, segmental bronchi. The segmental bronchi deliver air to a bronchopulmonary segment. Because this right bronchus is it's like short and wide, it tends to get foreign objects stuck in it more. So if somebody inhales a foreign object, it's more likely that it's going to get caught in the right bronchus than the left bronchus, or one of its branches that can go down into one of the lobar bronchi. This is a concern, for example, during dental procedures. We'll frequently see pieces of tooth or pieces of cavity that end up going down and getting lodged in that right main bronchus. The left main bronchus is longer and thinner. It's longer because it kind of has to like pass through and around stuff before it gets over to the left lung, just because of its positioning in the chest. So we see that it passes below the aortic arch, okay, so right below the arch of the aorta. It passes in front of the esophagus, okay, and the thoracic aorta, which, remember, the aortic arch, like, so the aortic arch is going to come up and then towards the back, and the thoracic aorta goes down back behind the heart. So the left bronchi is kind of going like this, and the aortic arch goes right above it, and then the thoracic aorta goes behind it. And then eventually the left main bronchus goes into the hilum of the left lung. And again, the main bronchus is going to split or V and give us lobar bronchi. The left lung has 2 lobar bronchi because the left lung has 2 lobes. And just like we saw, the lobar bronchi give rise to segmental bronchi, and the segmental bronchi each supply 1 bronchopulmonary segment. So branching off of the segmental bronchi, we have bunches of branches of bronchioles. 20 to 25 generations branch off the segmental bronchi, and we have numerous different types of bronchioles. Eventually, we get to terminal bronchioles and then respiratory bronchioles. Respiratory bronchioles are the last little bronchial segments, and they're going to open up into an alveolar duct. Okay, the alveolar duct opens up and brings air into the alveolar sac. So okay, say these are my bronchioles. Okay, I'll have a respiratory bronchiole here, my last little bronchiole, and that opens up onto an alveolar duct. The alveolar duct runs along the center of this alveolar sac. And the alveolar sac is literally a sac of alveoli. Remember, the alveolus is this little bubble with a really thin respiratory membrane that lines it. So the air is going to flow through the respiratory bronchiole into the alveolar duct, and as it flows down the duct, the air starts to enter each alveolus, right? And then we have actual gas exchange occur. So the respiratory bronchiole is feeding this one alveolar sac. And the walls of the respiratory bronchiole are actually thin enough for gas exchange to occur. Most of the gas exchange is happening in the alveoli just because of the massive surface area. But there is some gas exchange that can happen in the respiratory bronchiole because it is so small. That can't happen in the rest of the bronchial tree. Okay, so we see a lot here. Let's kind of talk through all of this. The one single tube is the trachea, okay? Here you see the trachea passing down. Initially up here, this is the cervical region of the trachea. It's up in the neck. And then this is our superior thoracic aperture. Remember, here's like the first rib. Okay, this is our manubrium. You see the jugular notch. So the trachea passes through the superior thoracic aperture and enters into the thorax, right? We're looking at the thoracic cage. Notice bifurcation of the trachea, we said, is when the trachea splits into the two main bronchi. And here you see the left bronchus and the right bronchus on this side. Bifurcation of the trachea, we said, happens right here at the sternal angle. So the joint between the body of the sternum and the manubrium is, you can palpate it, that's the sternal angle, that's right where the bifurcation is occurring. Also, we said that this right bronchus is shorter and wider, whereas the left bronchus is longer and thinner. It's got longer to go to get over to the left lung. After the main bronchi, we said that we split into the lobar bronchi. And then after the lobar bronchi, we split into the segmental bronchi. The segmental bronchi are each going to deliver air to one single bronchopulmonary segment. Okay, and I'll show you those on a picture coming up in a second. What else can we say here? Oh, okay. So all of these like kind of light bluish areas that you see, these are showing you cartilage. And cartilage is present throughout most of the bronchial tree, and the cartilage is there to hold the tubes open. Okay, so in the trachea and in all of the bronchi, we have cartilage there to hold the tubes open so that they don't collapse in the changing pressures during inhalation and exhalation. During inhalation, right, we don't want to collapse the tubes as we create this negative pressure or lower pressure in the thoracic cavity. So the cartilage is there to hold them open. Once we get down past the bronchi into the bronchioles, remember that the bronchioles have smooth muscle, and that smooth muscle constricts and dilates to change the size of the bronchioles. Okay, but we see cartilage here. Also, if you look right here, this is important. This is showing you a cross section taken like right here. If you take a cross section of the trachea, you'll notice that directly posterior to the trachea is the esophagus. Because of that, these cartilages that support the trachea cannot be circular. They are not complete circles, right? The cartilages that support the trachea are C-shaped. So you see this blue cartilage, and then you notice in the back, there is no cartilage. Okay, in the back, we have something called the trachealis muscle. Okay. And this is important because it allows for flexibility of the posterior aspect of the trachea. So this back area of the trachea right here is flexible. Okay? It can be pushed in. That allows for us to swallow food down the esophagus. Look at the esophagus right now. It is completely shut, right? It is squeezed closed. It's not like an open tube. When we swallow a bolus of food, the esophagus needs to expand to allow that bolus of food to pass. It can expand here or anteriorly into the space from the trachea. Back behind the esophagus is the vertebral column, right? And that's pretty stiff. That's not going to move out of the way. So that's why we have these C-shaped cartilages and why the posterior portion of the trachea has that flexibility. So we'll talk about the vasculature of the lungs. Remember, we said that arteries are carrying oxygen-poor blood to the lungs. That oxygen-poor blood is being pumped out of the heart by the right ventricle. So the right ventricle contracts to pump this oxygen-depleted blood out of the heart toward the lungs. From the right ventricle, the blood is going to exit the heart via the pulmonary trunk. So the pulmonary trunk is going to come up, and it is going to split into the left and right pulmonary arteries. This split happens at, again, the level of the sternal angle. There's a lot happening at that level of the sternal angle. So we see the pulmonary trunk splitting into the left and right pulmonary arteries. This happens anterior to the bifurcation of the trachea. Okay, so the trachea bifurcates into the bronchi at the level of the sternal angle, but that's happening posterior to this. So the pulmonary arteries are going to bring the blood towards each lung, and right before the pulmonary artery enters the hilum of the lung, it actually gives off a branch that's going to go to the superior lobe. Okay, then it enters into the hilum and then further branches from there. I'll show you a picture in a second. The arteries kind of follow the same trend that we saw with the bronchi. Okay, there are pulmonary arteries that divide and give us lobar arteries, right? They go to the different lobes. The lobar arteries are going to give rise to segmental arteries, and the segmental arteries end up bringing blood into each bronchopulmonary segment. Okay, so let's see what we see here. This is the right ventricle, and the right ventricle pumps blood out through the pulmonary trunk. The pulmonary trunk is going to split into the pulmonary arteries. So this is the left pulmonary artery. Okay, this passes underneath the aortic arch and comes over as the right pulmonary artery. The pulmonary arteries are going to split into the lobar arteries. You can't really see it over here. Well, let me erase and see. It's kind of hard to see, but this right pulmonary artery has this lobar artery that's going to the superior lobe, and then this enters the hilum. The right pulmonary artery enters the hilum. Then we can see our other lobar arteries. Again, the lobar arteries are going to come to different regions and end up giving us segmental arteries. Okay, so pulmonary trunk, pulmonary artery, lobar arteries, segmental arteries. Okay, on the left side, the same thing, right? The left pulmonary artery, we have lobar arteries, and we have segmental arteries. They're arteries because the blood is leaving the heart. Remember, they're carrying oxygen-poor blood, though. So then we have the veins that collect the oxygenated blood from the lungs and end up bringing it back into the left atrium. Intra-segmental veins drain blood to the adjacent bronchopulmonary segments. Okay, so an intra-segmental vein will be collecting from two different bronchopulmonary segments, and the intra-segmental veins end up merging into inter-segmental veins. The intersegmental veins follow along the septa. These septa go between segments in the lung. A septa is like a fibrous divider. Think of, again, like your nasal septum is this fibrous wall that divides the two sides of your nose. The septa in the lungs are the same thing. They're fibrous partitions that separate neighboring regions of the lung. So the intersegmental veins travel through the septa. Segmental veins end up uniting to form lobar veins. The lobar veins unite to form pulmonary veins, and we have two pulmonary veins on each side. We have a superior and inferior. So when we're naming the pulmonary veins, there's a right superior pulmonary vein and a right inferior pulmonary vein, left superior pulmonary vein, and left inferior pulmonary vein. Again, these are going to be bringing oxygenated blood and dumping it into the left atrium. The pulmonary arteries and veins that we just mentioned are supplying the actual lung tissue. We have additional arteries and additional veins that bring blood to and from the supporting structures. So think about the structures that go into the root, like the bronchi, as well as other supporting tissues and the visceral pleura, the tubes of the bronchial tree. All of these accessory structures have separate blood flow. The accessory structures, even there are branches that go to the superior esophagus, and then the whole bronchial tree from the main bronchi all the way down to the respiratory bronchioles. So the main bronchi, the lobar bronchi, the segmental bronchi, the respiratory bronchioles, the terminal bronchioles, everything in between receives blood from the brachial arteries. So where the brachial arteries come from, the left brachial artery and the right brachial artery come from two separate points, usually. The thoracic aorta, right? When the aorta, we have the ascending aorta, the aortic arch, and then the thoracic aorta goes back down behind the heart. The thoracic aorta gives rise to the left bronchial artery. The right bronchial artery can come from different places. Typically, the third intercostal artery will give rise to the right bronchial artery. And then we'll see the bronchial arteries kind of like pass along the main bronchi as they're going towards the lungs. I'll show you on the next slide. When we look at the veins, we have bronchial veins that end up collecting blood, and the right bronchial vein is going to drain into the azygous vein. The left bronchial veins drain into the accessory hemiazygous vein. So here, let's see. Over here, so we have the ascending aorta, the aortic arch, and then the thoracic aorta. The thoracic aorta would normally be coming down here, but that would be in the way. So that's why you see these hooks kind of pulling the aorta out of the way. And then the bronchi is kind of pulled up too, right? You see the trachea, and then you see the main bronchus, the right main bronchus, and then the left main bronchus would be coming over here. But we can't see the bronchial arteries on the back of the bronchus that way. So we kind of have it pulled up so that you can see the bronchial arteries on the back. So let me erase this. Okay, so remember we said the left bronchial arteries come off of the thoracic aorta, and that's what you see here. Here's the thoracic aorta, and then the left bronchial arteries you see coming off down the back of the left main bronchi going to the bronchial tree on the left. On the right, you can see the right bronchial artery right here. Okay, and in this case, it's coming off of the third intercostal artery. The third intercostal artery is coming like right here. Right, so you've got your first intercostal artery, your second intercostal artery, and then your third intercostal artery. Okay, so the third intercostal artery is giving way to the right bronchial artery. The thoracic aorta, here you see giving rise to the left bronchial artery. And then again, those branch all the way down the bronchial tree. Over here we see the main large veins that are involved in drainage from these accessory structures. So the azygous vein is this kind of larger vein that's coming up right here. Okay, that's the azygous vein. So you can see in here, okay, the bronchial veins draining into the azygous vein. The accessory hemiazygous is up here. And you can see the accessory hemiazygous is draining the left bronchial veins. Okay, so you see them coming up the bronchi, draining into the accessory hemiazygous. Okay, the hemiazygous goes down in this region, the accessory goes up. And then again, you can see like this ultimately all comes up and goes into the superior vena cava. And then from the superior vena cava, it'll drop down into the right atrium. Here are the bronchopulmonary segments. Okay, and you should learn these. Okay, I do expect you guys to know the bronchopulmonary segments. I'll put them up in lab. If this will be part of what you guys memorize in lab. But you do need to memorize these. Remember that each bronchopulmonary segment is fed by one segmental bronchus. Okay, so there's a segmental bronchus, which you can see here, that's associated with each of the bronchopulmonary segments. Here you see the upper lobe of the right lung, right? And these segments are going to the upper lobe. You see your middle lobe fed right here, and then your lower lobe is fed right here. Okay, and they're color-coded, right? So you can see this segmental bronchus is going up to the apical bronchopulmonary segment. You see this segmental bronchus is going to your posterior, and then the blue, this segmental bronchus is going to your anterior bronchopulmonary segment. And then medial and lateral. Okay, so medial, lateral, and then superior, anterior basal, and lateral basal. Again, you'll go through these in lab. We'll talk a bit about innervation of the lungs as well as the visceral pleura. The innervation that's going to and from the lungs are mostly located in the pulmonary plexus that are right around the root, right? So where everything's entering and leaving the lung, mostly anterior to the root, but there are some nerve fibers that are located posterior to the root as well. When we look at the pulmonary plexuses, there are both parasympathetic fibers and sympathetic fibers present. So the lungs are innervated by the parasympathetic nervous system and the sympathetic nervous system. We'll start by looking at the parasympathetic innervation. So just kind of think about it. Think about that the parasympathetic nervous system is your resting nervous system, rest and digest. It happens to be associated with secretions, so typically increasing secretions. Just keep that in the back of your mind. So the parasympathetic innervation of the lungs comes from the vagus nerve. Okay, the vagus nerve, remember, is cranial nerve 10. Okay, so cranial nerve 10 has both efferent motor fibers that are going to the tissues in the lungs, and it has visceral afferent fibers that are carrying signals from the lungs back to the central nervous system. So first, let's look at the efferent fibers, the fibers that are carrying commands to the lungs. The efferent motor fibers carry signals to the smooth muscle in the bronchioles, to the smooth muscle in the vessels of the lungs, and to the glands, mucus glands really, that are present in the bronchial tree. So they have kind of opposite actions in the bronchioles versus the vessels. When we have parasympathetic stimulation of the bronchial smooth muscle, this causes contraction of the smooth muscle. Okay, contracting the smooth muscle leads to bronchoconstriction, okay, to slow airflow or decrease airflow to that area. Parasympathetic stimulation of the smooth muscle in the vessels is going to inhibit that smooth muscle. So it's going to cause relaxation. Okay, so that's vasodilation. When we have parasympathetic stimulation, again, via the vagus nerve to the glands of the bronchial tree, this causes secretion. So increased mucus production and secretion in the bronchial tree. Again, I said parasympathetic is normally wet, right? It increases GI secretions. It increases bronchial secretions. It's the wet system. Okay, so these are the efferent signals that are going out from the central nervous system to the lungs and the tissue of the lungs. There are also visceral afferent signals that are being carried from the tissue back to the central nervous system. And these visceral afferent signals are mainly involved in protective reflexes. Okay, so carrying signals from the viscera, and they're associated with some sort of protective reflex. There are afferent fibers that come from the bronchial mucosa, and we think that these are involved with the cough reflex. So there's some sort of like sensory stimulation of the viscera, and this stimulates cough reflex. Again, this is protective. The afferent fibers of the vagus nerve have stretch receptors that are present in the bronchial muscles. So what these stretch receptors do is they're stimulated when there's a lot of stretch. So as we bring air in and as there's stretch occurring, that stimulates the receptors. And this is involved with preventing like overstretching, which would damage the tissue. We also have kind of along the same things, preventing overstretching. We have afferent fibers that carry signals from the intra-alveolar connective tissue. And these, again, are stretch receptors. So as the intra-alveolar connective tissue, so the tissue deep in the lungs, as it stretches, it can stimulate these these receptors, and that triggers something called the Herring-Brewer reflex. The Herring-Brewer reflex helps to limit overstretching of the rib cage, right? If we overstretch the rib cage, we're bringing in more air, we're going to overstretch our lungs and the alveoli, and again, that damages the tissue. So when we're inhaling deep, big inhalations, we don't want to overstretch and damage our tissues. So we limit that by triggering these reflexes via the vagus nerve. We also have afferent fibers that carry signals from the pulmonary vessels. And there are multiple different types of receptors that are present in the pulmonary receptors. We have this should be an O, B-A-R-O. Baroreceptors located in the arteries. That A is for artery. We have baroreceptors in the arteries that monitor pressure. And we have chemoreceptors in the veins that monitor for chemicals, right? So they monitor for oxygen, for carbon dioxide, for pH. And then these signals regarding pressure and chemical composition of the blood in the pulmonary vessels are sent up to the central nervous system via the afferent fibers of the vagus nerve. When we look at the parasympathetic innervation of the lungs and the vessels and the bronchi, the ganglia, right, the parasympathetic cell bodies are in the pulmonary plexuses that are along and following the branches of the bronchial tree. Okay, so the initial cell body is the brainstem, and the fibers go down to the parasympathetic ganglia and these pulmonary plexus, and then the postsynaptic fiber will go to the target cell. When we look at the sympathetic nervous system, sympathetic innervation of the lungs, the presynaptic cell, again, is central nervous system. The postsynaptic cells are in the paravertebral ganglia. Remember when we looked at the sympathetic nervous system, we said on either side of the spinal cord, right, or the vertebrae, on either side of the vertebral column, we had what we called sympathetic trunks, right? And they're like these lines on either side of the vertebrae that are on like interconnected ganglia. So the postsynaptic cells are located in these sympathetic trunks, and then there are longer postsynaptic fibers that carry signals to the lungs. When we look at the sympathetic nervous system, there are efferent motor fibers that are carrying signals out to the same effectors that we saw with the parasympathetic nervous system. So the parasympathetic nervous system was causing bronchial smooth muscle contraction, vascular smooth muscle relaxation, and secretion from the glands in the bronchial tree. Obviously, the sympathetic nervous system is going to have the opposite effects, right, or antagonistic effects. When the sympathetic nervous system is stimulated, the efferent fibers that go to bronchial smooth muscle cause relaxation of the smooth muscle, right? They inhibit the smooth muscle so that it relaxes. That causes bronchodilation or an opening of the bronchi so that more air can flow into the lungs so that we can pick up oxygen and get rid of CO2. The sympathetic nervous system causes contraction of the vascular smooth muscle. Okay, so that's going to cause vasoconstriction or constriction of the vessels. Constricting the vessels is going to increase the pressure and force the blood forward through the vessels. And sympathetic stimulation to the glands in the bronchial tree inhibits secretions, right? So we decrease mucus secretions via the sympathetic nervous system. Here we see a few things. So on this side, that is showing us the innervation to the skeletal muscles of both the thoracic wall and the diaphragm. So these are things that we've already talked about or you've looked at in lab. But remember the phrenic nerves on either side innervate the diaphragm. So the phrenic nerves you see here, coming from the cervical region, coming down and innervating the diaphragm. So the left phrenic nerve innervating the left half of the diaphragm, the right phrenic nerve innervating the right half of the diaphragm. Then coming through from T1 down through T11, you see your intercostal nerves, right? And your intercostal nerves, and then down here from T12, remember the subcostal nerve. But these intercostal nerves are innervating the muscles. In this case, we're looking at the intercostal muscles of the thoracic wall. Okay, so that's motor commands going out to the actual skeletal muscles. What we were just talking about with the pleural cavity and the pleura and the lungs was the autonomic nervous system. So the autonomic nervous system, remember, is the sympathetic nervous system and the parasympathetic nervous system. And that's what you see over here on this side. The parasympathetic nervous system, again, remember, is coming from cranial nerve 10, the vagus nerve. And we see the presynaptic neuron cell bodies are going to be up in the central nervous system. The fibers come down via the vagus nerve, and they're going to synapse closer to the target cell, right, in the brachial plexus, or not brachial, brachial's arm, and the bronchial or pulmonary plexus. So they synapse in the pulmonary plexus that follow all along the bronchial tree, and then ultimately send to effectors, right, that include bronchial smooth muscle, vascular smooth muscle, or glands in the bronchial tree. There's also the visceral afferent fibers, right, that are carrying signals in. And these visceral afferent fibers, remember, are important for protective reflexes. Okay, reflexes regarding pressure, chemical composition of the blood, but then also like the cough reflex and stretch reflexes to prevent overstretching of the lungs and the thoracic cavity. So the sympathetic nervous system is shown in red. Remember, the sympathetic nervous system, the synapse is occurring here in this sympathetic chain, right? We have the sympathetic ganglia here, and our postsynaptic cell body is located in that ganglion, so in the sympathetic chain. And then we have our postsynaptic fiber that goes out and again innervates the same targets. We're still innervating vascular smooth muscle, bronchial smooth muscle, and glands. We're just having opposite effects. The lungs can collapse when anything disrupts the surface tension between the visceral pleura and the parietal pleura. Remember that serous fluid that's present in the cavity creates surface tension, and that holds the two layers of the pleura together. And essentially that's holding the lungs out to the thoracic wall. It's keeping the lungs expanded. So anything that disrupts that surface tension can cause the lungs to collapse. Remember that the lungs are really elastic. So if there's nothing holding them out, that elasticity shuts them, snaps them shut. We call that atelectasis. Now, there are multiple different things that can cause this. Up here it says air entry into the pleural cavity. So if there's some sort of a penetrating wound that tears the parietal pleura. So this can be from a bullet, this can be secondary to a fractured rib. Anything that tears that parietal pleura can allow air to enter into the pleural cavity. That can disrupt the surface tension. In that case, we call it a pneumothorax. We can see that there are multiple other things that can also cause the lung to collapse. Really quick, just note that, remember, the pleural sacs are separate. They're not interconnected with each other. So one lung can collapse without affecting the other. You can have a pneumothorax on the right side or a pneumothorax on the left side, and the other lung is still working appropriately. So a pneumothorax occurs when there's a penetrating wound in air in the pleural cavity collapses the lung. A hydrothorax occurs when it's fluid accumulation. So fluid can leak through the visceral pleura into the pleural cavity. And fluid accumulation in the pleural cavity can collapse the lung, and that's again a hydrothorax. When the fluid leaks into the pleural cavity, we call this pleural effusion. A hemothorax occurs when blood from a chest wound accumulates, collapsing the lung. Heme, again, refers to blood, right? Hydro refers to water or fluid. So a hemothorax, when the blood accumulates from a hemothorax, typically this blood is coming from an intercostal artery. So from some sort of trauma that breaks the intercostal artery. Chylothorax comes when it's lymph that's accumulating. So when the thoracic duct tears, or when a thoracic duct tears, the lymph can accumulate, again, collapsing the lung. Pleuritis is inflammation of the pleura. And this you can tell by the word. Itis means inflammation. So pleuritis is inflammation of the pleura. Remember that the pleura are typically smooth, moist membranes. And the serous fluid, along with how smooth they are, allows them to slide and glide nicely alongside each other. They're important because of that lubrication. When pleuritis is present, this inflammation makes the pleura rough, and now they don't slide nicely alongside each other. Instead, during inspiration and exhalation, when there's changes, right, when there's movements in the thoracic cavity, now there's friction that occurs. When someone has pleuritis, you could typically hear this friction. It's called a pleural rub, right? You hear the friction as the pleura rub. And this again can be heard with the stethoscope upon auscultation of the lungs. Acute pleuritis is typically also painful. It's marked by sharp stabbing pain, especially on exertion. So any physical activity, and this can be mild exertion. By exertion, I don't mean working out at the gym or going to run 5 miles. I mean walking up the stairs to the 2nd floor of your house, or maybe walking to go get the mail. That's enough exertion to cause a sharp stabbing pain on the affected side. Thoracentesis refers to the procedure where we remove some sort of fluid from the pleural cavity. And we can be removing blood if it's a hemothorax. We can be removing pus or whatever fluid is present if it's a hydrothorax. When we do a thoracentesis, a hypodermic needle is inserted into the intercostal space, right, the space between the ribs. And when we insert the needle into the intercostal space, it's important to make sure that you're far enough above the rib that you don't hit the collateral branch of the intercostal artery. So don't just put the needle directly on the rib and slide at that point. You have to be far enough up into that intercostal space so that you're not hitting the collateral branch. Okay, so over here, the circle is indicating where the pleural effusion is. Again, this side looks good. That's what we should be seeing. But all of this cloudiness is showing the fluid buildup. Looking over here, remember that the parietal pleura is lining the body wall and the diaphragm, the mediastinum, and then the visceral pleura is on the surface of the lungs. So all of this fluid accumulation down here is the pleural effusion. Thoracentesis is the procedure we use to remove that fluid. This is a typical position that the patient will be in, sitting and then leaning forward with the arms and the head down on whatever they're leaning on. This kind of opens up the intercostal space because you're going to place the needle in that intercostal space after numbing the area in order to withdraw the fluid. You can send the fluid for testing, and sometimes that can help you diagnose, for example, an infection. But just removing the pleural effusion itself, removing some of the fluid, is going to help the patient breathe better and provide some symptomatic relief. Ultrasound, you can use ultrasound to guide placement of the needle as well. Ultrasound will help you kind of visualize the area so that you can find the best insertion point. So we frequently auscultate and percuss the lungs. Auscultation is when we listen to the lungs and we're listening to assess airflow, right? Is there any obstruction to airflow? Percussion is when we tap on the lungs, and tapping on the lungs allows you to assess the density of the lung tissue. So with percussion, if the lungs are air-filled, which they should be, then you'll hear a resonant sound. If they're fluid-filled, you'll hear a dull sound, so like in pneumonia. If they're solid, you'll hear a flat sound, so as like a tumor or some sort of a mass is present. When we percuss and auscultate the lungs, you should assess all the way up to the neck, because remember, this is where the apex of the lung is. So make sure that you're assessing the entire lung, not just the inferior portions of the lung. To assess the base of the lung, remember that the posterior surface of the inferior lobe is at about T10 on the dorsal side. We said that the pleural cavity goes down to T12, right? But that's the pleural cavity. And remember, we have space down there underneath the base of the lung. So the actual lung itself is at the level of T10. Aspiration occurs when something enters into the respiratory tract. So aspiration, we can aspirate liquids, aspirate solids. Typically, if some foreign object is going into the lungs, it's more likely to lodge in the right bronchus. We talked about that. That was just because of the anatomy of the bronchus. Aspiration can lead to aspiration pneumonia, and this is more common in patients who has some sort of a comorbidity. So nursing home patients, patients with breathing tubes, patients with chronic respiratory infections are more likely to get aspiration pneumonia. Hospitalized patients. Lung resections. So at times we need to resect or remove part of the lung. For example, if there's cancer present, and we can remove all different amounts of lung depending on how severe or how progressed it is. A segmentectomy is removal of one bronchopulmonary segment. Tumors and abscesses are frequently contained in just one segment. There is some pulmonary skeleton that kind of surrounds the segment. So frequently we'll see that it's contained in one segment, and doing a segmentectomy will remove that abscess or that tumor. The surgeon follows the interlobar veins that pass between the segments as kind of a guide. A lobectomy is when we remove an entire lobe of a lung. And then pneumonectomy is the removal of an entire lung. It's possible for a clot, for example, in the leg, to break off. And then we have an embolus that's traveling through the bloodstream. And that embolus can go back to the heart, go through the right side of the heart, and get sent to the lungs. And the vessels in the lungs are smaller than the vessels that the embolus has been traveling through. So the embolus can get caught or lodged in the pulmonary arteries or the pulmonary vessels. If the embolus, a large embolus from the leg, gets stuck in a pulmonary artery, okay, that's blocking a lot of blood flow, then we call that a pulmonary embolism. Because we're blocking so much blood flow to the lung, This can cause acute respiratory distress because we're decreasing oxygenation of the blood a lot, right, vastly. Now, if the embolus is medium-sized, then it's not going to get stuck in the pulmonary artery. It's going to make it through the pulmonary artery, but then it gets stuck in the smaller arteries. So a medium-sized embolus can block blood flow to a bronchopulmonary segment. This is called a pulmonary infarct. And instead of causing respiratory distress, this typically will cause necrosis or death of the lung tissue that's affected, the bronchopulmonary segment that's distal to the infarct. A bronchoscopy is a way we use a scope to examine the inside of the tracheobronchial tree. Okay, so this is a bronchoscope that we're using, and we feed the scope down, in the mouth, down the throat, the larynx, and into the trachea. Here, what we're looking at right here is something called the carina. So the carina is this ridge right here that's at the junction where the trachea is going to split or bifurcate and become the two main bronchi. So this ridge is important to visualize because it gets distorted when cancer cells have metastasized to the tracheobronchial lymph nodes. So frequently when we're doing a bronchoscope, the carina is examined to check for metastasis.